Assalamu alaikum wa rahmatullahi wa barakatuh, everyone. Welcome to this PAL session on the classification of anemia. Considering this is the first time I'm teaching the 17th batch, just a little bit about myself. My name is Abdelrafour Houdane. I am a 10th batch graduate, so a recent medical graduate and currently interested in ortho. Really, really happy to see a bunch of unfamiliar faces. And hopefully, as we go through this session, it can be a useful one. As we're going through the classification of anemia, this is kind of like the very typical kind of like structural breakdown. We're going to start with a little cheeky introduction. We're going to dive into the clinical features and some important investigations, classification of anemia, types of anemia, and then we'll wrap up with some example questions. If at any point you have any questions, just throw them in the chat and I'll be checking with you guys intermittently. So anemia is simply defined as a low hemoglobin. Now, this is very important to know that it's specific for the patient's age and gender. So anemia is low hemoglobin for a specific age and gender. This is very important because different people have different normal thresholds. An adult male usually ranges from 13.5 to 16.6 grams. Obviously, don't remember these numbers. This is just for the sake of completion. So in order for a man to be considered anemic, usually the hemoglobin is below 13.5. Compare that with, for example, a child. A child usually the hemoglobin is normally much lower because they're smaller in size. So anemia is defined as when the hemoglobin drops below 11. You will notice that babies tend to have a higher threshold. That's because usually the body uses up a lot of iron and needs a lot of iron during that early growing process. So this kind of slide is just there to emphasize that anemia is defined as low hemoglobin for the specific age and gender. Now, anemia is one of those topics which is very, very, very important. It's super high yield for exams. It's super high yield for board exams for step 1 and step 2. And it's one of those concepts that you're going to be hearing about for the rest of your medical career. Regardless of whatever specialty you go into, whether it's surgery, whether it's internal medicine, anemia remains a very, very important topic. Now, medicine in general, as you guys are going to learn throughout medical school, is really built around this trifecta approach for every single patient. Whenever we approach a patient, we always start with a very, very good history, a strong physical examination, then we do some labs and imaging. This is how we diagnose nearly every single case. So anemia is not immune to this. We still approach every single patient with a history, a physical examination, then we do some labs and imaging to confirm a diagnosis, and that's the general process. Now, in order to be able to take a good history or a good physical examination, it is important to identify the different clinical features that anemia will present with. We know that they will present with a lot of these non-specific symptoms like fatigue and tiredness, but it's important to know anemia also has a very, very wide range of symptoms. Some important kind of specific symptoms can let you think of specific anemias, and some of them are very non-specific. Most anemias tend to present with some degree of paleness. Most anemias tend to present with fatigue, lethargy, exhaustion, etc. Now we're going to go over the specific clinical signs that we tend to see in patients who have anemia. One of the most common is pallor or very pale skin, pale palms, pale conjunctiva, or even pale tongue. And obviously, the more severe a patient's anemia is, the more pale they're going to be, and the more you can pick it up when you do your physical examination. And you can see in this image, when you compare those two pictures of the palms, one patient is much, much paler. Same thing when you look at the lower conjunctiva of the eye, which you might take in the pro sessions, you will notice that we always look at the conjunctiva for pallor. What we're looking for is, does this patient have any signs of anemia? It's supposed to be this nice pink reddish color. If it's not, and if it's very pale, that's a sign of anemia. And most anemias will tend to present with pallor. Chorionoikia, or spoon-shaped nails, unfortunately the image is duplicated, but basically is a very characteristic finding in patients with iron deficiency anemia. So their nail bed kind of gets striated, deformed, and becomes curved from the outside, so it looks like a spoon, allegedly. Secondly, you have angular stomatitis, or this kind of like inflammation at the corner of the lips. This is seen in iron deficiency anemia, but it's also seen in patients who have a folate or B12 deficiency. As we're going to see later on, patients who have folate deficiency or B12 deficiency are at risk of developing a specific type of anemia known as megaloblastic anemia. But here's another sign, angular stomatitis. Jaundice is another clinical finding, and that's going to be very, very yellow skin or very yellow eyes in the sclera. This is mainly seen in hemolytic anemias. The main characteristic finding in hemolytic anemias is basically there's some undergoing hemolysis. Hemolysis, which means the breakdown of red blood cells. When you break down red blood cells, they spill over a lot of material inside the cell that leads to an increase in bilirubin, and that will lead to jaundice. So this is usually mainly seen in hemolytic anemias. Then you have bone deformities. That's usually seen in advanced stages of thalassemias, like thalassemia major. They begin to develop these like classic chipmunk faces. What basically happens here is the body tries to produce a lot of RBCs because the RBCs that are being the RBCs, the hemoglobin that is being produced is deformed. So the body is trying to compensate by pumping out a lot of new RBCs that will lead to the bone marrow to kind of increase in size, and that will deform the bone. So that's mainly seen in thalassemias. Leg ulcers are seen in sickle cell patients. Again, this is because of like some clotting that happens. These sickle-shaped RBCs plug the distant capillaries, so there's poor wound healing, and those areas tend to develop ulcers. So again, this slide is again just to re-emphasize anemias do present with a wide range of symptoms. It's important for you to kind of know how they present so you can pick it up when you're doing a physical examination or taking history from a patient. Do we have any questions so far? Okay, so let me see. Okay, so now moving on to investigations. Like I said, the cornerstone of approaching any patient is a history, a physical examination. Oh, we have a question. What types of thalassemia causes bone deformities? Now, usually this happens, I believe, in thalassemia major, the more advanced type, when you have more than 3 alleles that are deformed. Minor thalassemias usually tend to just develop with like mild anemia, but the more severely advanced, I believe it's called thalassemia major. They're the ones who classically present with these bone deformities. Moving on to investigations. Now, anemia investigations are obviously going to be based on blood tests. CBC, or your complete, wait, I don't know what CBC stands for, honestly, but CBC is your first line test. Okay. You have other tests, sorry, complete blood count, completely slipped my mind. Anywho, CBC is your first line test for any patient in general, but it's also very specifically important for patients with anemia. And you will do a bunch of other tests that will help you pick up specific diseases, which we're going to see later on. This is an example of a typical kind of CBC report that will come out from a lab. You have a patient, you order a CBC report. This is what's usually come up. You have the test name on the side, you have the result, and obviously you have the reference range because who has time to memorize all the different numbers? And this is where the classic CBC column will have. You'll have an RBC count or a red blood cell count. You're going to have the hemoglobin levels. You're going to have the hematocrit. Then you're going to have a bunch of weird names. You have the MCV, you have the MCH, the MCHC, the RDW, a bunch of stuff. And it can get very confusing at first, but this is very, very important and very high to know for you to know what each of these words represent and what does it mean clinically when they are increased or decreased. So let's go through them. We start with, again, as we said, anemia is low hemoglobin for a specific age and gender because that threshold will change when you're looking at the age or the gender of the person. Hemoglobin, when you check it on your CBC, is simply the concentration of hemoglobin in the blood. It is a total hemoglobin overall. Hematocrit is the volume of RBCs in a unit of blood. And the way how it used to be historically calculated is you'll put a bunch of whole blood sample on a test tube, you'll centrifuge it, and then all the RBCs will accumulate in the bottom, and then you do some calculations. Now it's all kind of like digital and mechanical is done by the machine. Now, in some cases, in patients who have anemia, the hematocrit will decrease. And there are some conditions where you have an increase in the number of RBCs. These usually tend to be like malignancies, like polycythemia vera, where the body is overproducing RBCs. Now, this will present with a elevated hematocrit. Thing is, though, the hematocrit is not the best source of detecting anemia because if a patient is diluted, let's say, for example, received a lot of like fluids, like IV fluids, you will increase the amount of plasma, so the RBCs will be diluted, so the hematocrit will be artificially low. And vice versa, if you're very dehydrated and the plasma volume decreases, the hematocrit will artificially increase. So usually we use the hematocrit in combination with the hemoglobin. If the hemoglobin and the hematocrit are both low, we know that we're dealing with a anemia situation. So this is what the slide says. Dilution decreases the hematocrit and dehydration artificially increases the hematocrit. But again, the hematocrit is more relevant when you're looking at those conditions. I don't know if you've taken them yet or not, but it's usually seen in polycythemias. Next, we have the red blood cell count. It's just the total number of RBCs in the blood. Very simple, very intuitive to understand. And now we move on to the tricky ones. We start with the mean corpuscular volume, or the MCV. This is the average size or the average volume of a single RBC. And this is probably the most important one of these kind of like blood tests that you should know. Why? Because the MCV plays a very important role in the classification of anemias. But first off, the normal MCV is usually 80 to 100 femtoliters. I think you should memorize this number because it's very simple. It's 80 to 100. And if the MCV is below 80, we define this as microcytic. So microcytic anemia is an anemia where the MCV is less than 80. If the patient has a normal MCV, which is 80 to 100, that is defined as normocytic. And if it's above 100, we call this macrocytic. And again, this will become very, very important when we deal with the classification of anemias because we tend to label anemias as either being microcytic, normocytic, or macrocytic. And this is how they look. Again, macrocytic are very big RBCs, microcytic are very small RBCs, and normocytic are the normal size. Usually, we like to combine when describing anemia. We want to describe the size of the RBC and also the amount of hemoglobin inside. And we call this the MCH, the mean cell hemoglobin. It's the amount of hemoglobin inside each red blood cell. When the MCH is low, when the amount of hemoglobin in each cell is low, we call this a hypochromic anemia. If the MCH is normal, we call this a normalchromic. We don't really have a hyperchromic because if you have too much hemoglobin in the cell will burst and die. So we just have a hypochromic and a normalchromic. So again, the MCH and the MCV, sorry for the typo, is very important in the classification of anemias. We tend to define anemias using those two parameters. There's something else called the mean cell hemoglobin concentration. This is not the amount of hemoglobin in the cell, rather it's the concentration of hemoglobin inside the cell. The MCHC is kind of only important in some hemolytic anemias and a specific type of anemia called hereditary spherocytosis. In these two conditions, the MCHC is elevated and it's used to kind of confirm or it's one of the clues that this is a diagnosis that the patient has. But for the most part, most anemias have a normal MCHC. Then we have something called the red cell distribution width, or just the RDW. The RDW is a measurement of the variation of sizes between the RBCs. It looks at the biggest RBC and the smallest RBCs and sees how likely are they the same size. When the RDW is high, that means there's a big difference or a big variation in the RBC sizes. As in, you have some small RBCs, some normal RBCs, some big RBCs. However, if the RDW is low, we say that there is minimal difference. Most of the RBCs are the same shape. Doesn't matter if the RBCs are all big, they're all uniformly big. There's not some big ones and not some small ones. And again, we care about the RDW because iron deficiency anemia and the minor thalassemias both kind of present very similarly. One of the ways we can differentiate them, and they love to ask this question in steps, is to look at the RDW. The RDW is elevated, it's more likely to be iron deficiency anemia. And if it's near normal, it is most likely to be a thalassemia. Finally, we have the reticulocyte count, usually given as a percentage. Now, a reticulocyte is kind of one of the precursors to RBCs. If the reticulocytes increase, or the percentage of reticulocytes increase in the blood, that's basically a sign that the body is producing a lot of RBCs. So think of it as a way to determine if the body is overproducing RBCs or not. And that's how they look on blood smear, is these larger, oval, kind of like, they look like an RBC, but bigger. And they contain a lot of those DNA material because they have not undergone the process that kind of eliminates the nucleus. So again, we usually see an increased reticulocyte count in hemolytic anemias. Again, hemolytic anemias are anemias where the body is destroying the RBCs for some reason, and to compensate, the body begins to pump out more RBCs. So a decreased reticulocyte count will be seen in conditions where the body is not producing enough RBCs. We see this in nutritional anemias, and it makes sense. If, for example, someone is iron deficient or doesn't have enough B12 or doesn't have enough folate, they don't have enough fuel or enough resources to make more RBCs. So production slows down, and that will be reflected by a decreased reticulocyte count. And that's basically the main parameters gone through. Any questions so far? Anything confusing? Okay. So again, this is just like you have to go through the slides a bit just to kind of cement this into your mind and try not to get confused between them. But you're going to be having so much exposure to these concepts by the time you reach later towards your medical career. It's going to be very, very self-explanatory. Now we move on to classification. One kind of very interesting thing about medicine, and you're really going to discover this as you go through uni and as you go through like your career, doctors love to classify things. And that's because classification is so important in mentally organizing stuff. And it's an approach you should do whenever you study. Don't just learn things in a chaotic order. Try to classify and organize things to remember them. For example, this is just like a huge mess of different anemias. But if you mentally organize them into categories, it is much easier for you to both remember, mentally kind of identify shared similarities and differences between different ones. So this is the same thing organized. As you can see, one of the most classical way to classify anemia is as either microcytic hypochromic, normocytic normochromic, or macrocytic anemias. Under the category of microcytic hypochromic anemia, again, these are going to be very small RBCs. It's stuff like iron deficiency anemia, thalassemias, lead poisoning, and sideroblastic anemia. In normocytic normochromic anemia, you have stuff like anemia of chronic disease, which is basically a type of anemia seen in patients who have chronic disease and high levels of inflammation in their body. There's some different like markers that happen that cause the body to stop producing enough RBCs. Then you have the typical hemolytic anemias. Like we said, they present with jaundice, stuff like sickle cell anemia, and paroxysmal nocturnal hemoglobinuria, which we'll probably take at some point, and hereditary spherocytosis. These are all examples of normocytic, normochromic anemia. On the other side, the macrocytic anemia, you would have stuff like B12 deficiency and folate deficiency. When the cause of the macrocytic anemia is the B12 or folate deficiency, we call it a megaloblastic anemia. So classification is very important. And this is a beautiful slide from first aid showing the exact same thing. It's a beautiful way to organize anemias either as microcytic, normocytic, and macrocytic. Obviously, I'm pretty sure, I don't know to the extent of how much heme you guys are taking, because historically speaking, I think you guys are the first batch to have heme and foundation mixed together, which is honestly very cruel. But eventually you will take enough information to be able to organize all these different conditions. But most important to know, you have microcytic anemias like iron deficiency anemia and thalassemias. You have normocytic, which either could be hemolytic or non-hemolytic. And then you have the macrocytic anemias like megaloblastic ones. Now, obviously, it would be very nice if that was it and that was the only classification system you gotta know. But unfortunately, in your slides, there's this kind of weird different system that they want you to know, apparently. And this is by classifying anemia based on the reticulocyte count first. So you have conditions which are low reticulocyte count or hypoproliferative. And this is very logical. We said that the proliferation is heavily linked with the reticulocyte count. A low reticulocyte count means the body is not producing enough RBCs, and vice versa. If a patient has high proliferation or high reticulocyte count, that means the body is trying to pump up RBCs. In the hyperproliferative category, you have either bleeding and hemolysis, which makes sense. The others are usually low reticulocyte count. One important concept, and it's about blood loss, is that in the acute setting, acute blood loss initially will have normal hemoglobin. It's with time, if let's say after 2 or 3 days of this kind of like acute blood loss, it takes time for the body to register that, hey, oh crap, I'm losing blood. Let me start increasing the factor of RBCs. So it takes a few days before it turns into a hyperproliferative. But in the acute setting, let's say you're just playing rugby and you just get a huge laceration in your forehead and you're bleeding, your hemoglobin will be normal. If you get tested in the ER, your hemoglobin will be normal. Give it a few days of continuous bleeding, and yes, it will eventually become into a hyperproliferative anemia. Take it more chronic, and let's say someone's been bleeding for months, then these patients will present with a hypoproliferative anemia. Usually it's going to be stuff like an iron deficiency anemia because you're exhausting the iron stores. But initially, it's going to be a hyperproliferative anemia. And again, chronic blood loss usually will present with your classic iron deficiency anemia. Initially, your body tries to compensate by pumping up the RBCs, but then there's just simply not enough iron in the body, and the factory begins to slow down once again. Hyperproliferative anemias usually are hemolytic, stuff like sickle cell anemia, hereditary spherocytosis, G6PD, all these things that you're going to take a lot in biochemistry. So these are usually hyperproliferative. The body is trying to compensate the hemolysis by increasing the amount of RBCs. Now, this is the same concept. You have premature destruction of RBCs, and the body compensates again by increasing the reticulocyte count. Now, these hemolytic anemias can either be hereditary or acquired. Classic examples of hereditary anemia is like sickle cell disease and G6PD deficiency and hereditary spherocytosis. And acquired types are usually stuff like autoimmune hemolytic anemia. Someone gets infected with hepatitis B and they start producing antibodies, and it kind of like jacks things up. And that kind of concludes this section on the classifications of anemias. We are very, very close to being done. So do we have any questions so far? Okay, perfect. So now we move on to types of anemias. Now, in the slides, they really mentioned 3 types of anemias they want you to know. Number 1 is iron deficiency anemia. Number 2 is megaloblastic anemia. And finally, aplastic anemia. We start with what is probably the most important anemia you should commit to memory, not only for you, but for your families and for your community. That is iron deficiency anemia. Iron deficiency anemia is basically when you don't have enough iron in the body and your body simply can't make enough RBCs because hemoglobin kind of low-key needs iron. Now, the most common cause of it is going to be chronic bleeding. This is usually the most common example. You can have iron deficiency anemia if you have a very, very poor diet. But for the vast majority of the population where the diet is not a problem, the most common cause is going to be chronic bleeding. Now, the most, like some examples of chronic bleeding could be a gastric ulcer. Someone who has peptic ulcer disease, has an ulcer in the stomach that could slowly trickle small amounts of blood, but over a chronic period of time, they are chronically bleeding. So that could lead to iron deficiency anemia. In women, it is very, very important when you're taking history to ask about the period, to ask about menstruation history, ask how heavy are the menses, how many pads are being soaked, because heavy menses is one of the most common causes of iron deficiency anemia in women. Finally, if the patient is an older patient, let's say over the age of 60, the general rule is any patient over the age of 60 who is presenting with iron deficiency anemia is colorectal cancer until proven otherwise. Colorectal cancer can be very silent with the only exception of iron deficiency anemia. So it's very important to test any old patient with iron deficiency anemia and make sure they don't have colon cancer. In general, when you do your investigations, you took history of a patient and you're suspecting iron deficiency anemia, your next step is to do a blood work. First thing you can see is a low hemoglobin, confirming that this patient actually has anemia. Patients with iron deficiency anemia have microcytic hypochromic anemia. They also have an increase in the RDW, which means they're going to have some big RBCs and some small RBCs and some normal RBCs, and there's going to be a lot of variation in size. This is a very heterogeneous RBC count. Finally, the reticulocyte count is going to be decreased. Again, we don't have enough iron in the body. The factory of RBC production cannot be maintained. But then the confirmatory test to confirm a patient actually has iron deficiency anemia is via doing iron studies. These are a bunch of studies that will look at the amount of iron in the body, and most importantly, they'll be looking at something called ferritin. Ferritin is a storage form of iron. If the ferritin is low, you know it's iron deficiency anemia. Case closed, can give the patient oral iron, or if the patient has really severe anemia, you can even give them IV iron, but the treatment is simply going to be iron replacement, and this is a very important caveat, and uncovering the underlying cause. You have to find out why the patient has iron deficiency anemia. Iron deficiency anemia could be the least concern. It could be masking a patient who has an ulcer, could be masking a patient who has a cancer. So you have to find out why the patient is bleeding, and you treat the anemia by giving the patient iron. So this is what the slide basically goes over. Then we move on to megaloblastic anemia, which is a type of macrocytic anemia caused by a vitamin deficiency. Usually that's either going to be a B12 deficiency or a folate deficiency. But the idea is that both of these will lead to an impairment in the DNA synthesis. How exactly? I'm going to be completely honest with you. It's been so long since I took this, I completely forgot. And I genuinely hope I never have to go through this again. But I think you guys will eventually understand how this happens. But the general kind of idea is you have B12 or folate deficiency. The DNA synthesis pathway can happen because some enzymes need B12 and some other enzymes need folate. And then basically the nucleus of the RBC is going to be very, very big and filled up with DNA parts that are not fully formed. And therefore, the cell is going to be big. And when we have an RBC greater than 100 femtoliters of MCV, we call this macrocytic. Here you can see the megaloblasts, which are these large RBCs filled with these nuclear fragments. And also another sign of B12 or folate deficiency is hypersegmented neutrophils. The nucleus has so much extra lobes. Usually they have around 3. You might find like 5 or 6 lobes of that nucleus. This is very classic for B12 or folate. Again, treatment is going to be replace the B12, replace the folate, and find out why they have that deficiency. Finally, we have the last one, which is aplastic anemia. This is an example of a hypoproliferative anemia. So what would you expect the reticulocyte count to be? Will it be elevated or will it be decreased? Let me know in the chat. So patients with aplastic anemias, do they have high reticulocyte count or a low reticulocyte count? What do you expect to see on testing? And yep, absolutely correct, everyone. It's going to be low reticulocyte count. Perfect. So here, the central pathogenesis or the central cause of aplastic anemia is some sort of damage or some sort of decrease in hematopoietic stem cells in the bone marrow. Now, as you know, hematopoietic stem cells, they make RBCs, they make WBCs, they make platelets. Causes are very wide, and I don't think you have to know this at your level, but for the sake of like education, stuff like chemotherapy agents, some viruses, some toxins can lead to damage of those hematopoietic stem cells, and you will present with a decrease in RBCs, a decrease in WBCs, and a decrease in platelets. That decrease in RBCs gives us the aplastic anemia. In general, if all 3 are low, we call this condition pancytopenia. Pancytopenia. Pan is going to be used whenever you're speaking about all bloodline, all cells are decreased, and cytopenia just means low cells. As you go through medicine, I think it's very good to kind of pick out what do the different words kind of mean. So penia means a decrease in something in blood. Cyto is to do with cells. So cytopenia is decreased cells, and pancytopenia means all 3 blood cells are decreased. When you take a biopsy of the bone marrow, you will notice the bone marrow is kind of empty. I put pictures there from the slides. Obviously, you gotta see how normal bone marrow looks like. It looks nice and chunky and big and nice and like thick. This is just really empty. The big white spaces are like adipocytes, just fat replacing the bone marrow because it lost a lot of those hematopoietic stem cells. And that kind of like wraps up iron deficiency, megaloblastic, and aplastic anemias. Before we go and throw just a few questions, just to see if you guys understood the concept, does anyone have any questions for me on anything we've taken so far? And I'm gonna use this time to just like have a small swig of my karkade, which is about to finish. Okay, I don't see any questions, so I'm just gonna move on and ask you guys a bunch of questions. Let's say we have a patient comes in with fatigue to your clinic, you do a physical examination, you take a history, and you take a CBC. This is your CBC results. Hemoglobin is 9.7, the MCV is 69.7, and the MCH is 22.3. My question to you is, what type of anemia do you think this patient has? Is it A, microcytic hypochromic? Is it normocytic normochromic, macrocytic, or the patient does not even have anemia? Okay, you guys, like literally, bam, unanimous A. Absolutely correct. This is a patient with a microcytic hypochromic anemia. You can see that the MCV is low, the MCH is low, and let's say you do a iron test and you find out the ferritin is low, and you diagnose the patient with iron deficiency anemia. Here's another patient. This is a woman this time. She comes around with a hemoglobin of 13 grams, a MCV of 88, and an MCH of 30. Is it A microcytic hypochromic? Is it B, normocytic normochromic? Is it C, macrocytic? Or is it D, no anemia? Okay, I love this question because now we have two groups of students. Some people chose B and some people chose D. Now, this is where it gets kind of interesting because it's very important that's why I kind of emphasize at the start, anemia is defined as low hemoglobin based on age and gender. If this patient was a male, everyone who chose B is absolutely correct. However, 13 is still within range, within relative range of someone who could be, for example, a child or someone who could be a woman. So in this case, the correct answer is going to be D, no anemia. If it was something like 11, then it is more likely for it to be B, normocytic normochromic. So this is no anemia. And this is, I don't think they would ever give you tricky questions like this in the exam, but just kind of was an example that you always want to look at the reference range based on the patient that you have. But otherwise, if I told you this was a male, anyone who chose B is absolutely correct. This is a normocytic normochromic anemia, but because this is a young child, it's going to be D. Final question. Patient comes in with a hemoglobin of 6.5, an MCV of 113, and an MCH of 27. What type of anemia does this patient have? It's no fun when you guys are too smart, mashallah. Okay, yes, it's a macrocytic anemia. So my question for you now is like a follow-up question. What could be the cause of his anemia? Absolutely correct. Whenever you see this macrocytic anemia, I really want you guys to think of B12 and folate deficiency. And that basically sums up this lecture. Thank you so much for listening. I hope you guys found this useful and enjoyable. Thank you so much for coming during National Day. I know it's not easy to celebrate when you have an exam right around the corner, but inshallah, may Allah make this easy for you guys and make this first exam go smoothly. Don't worry too much about it. Like, I know it's a bit stressful, but it's inshallah the start of a very exciting journey. And if you guys have any questions on anything to do with medicine and anything to do with like specialties or how to approach studying, etc., I've left my Twitter account, my professional Twitter account on the screen down there.